So good afternoon. It's a great pleasure to be here, especially in this session. So I'm going to be calling Dr. Wayne Danter, who's the president of the Clinical Outcome. So we started this afternoon with Dr. Varda Rutter giving an amazing introduction about how peptides may change leaf-omini patients' lives, because it may be a way to get back, fold back mutant P53 into wild type P53. So we're going to have two people speaking to us today about these new peptides. Thank you.
Thank you. Hello, everyone. Okay, so I'll just go back. I wanted to start out by thanking the organizing committee, and in particular David, for inviting me to come here. And I don't get to nearly enough meetings at which there are families involved, and I want to just feed back to you what a wonderful experience that is, and I want to thank you for the opportunity to tell you this story. I'm actually a newcomer to research in Leaf-Romani syndrome. About 5 years ago, we started working on a program for P53 mutations, and those were somatic mutations. And about 2 years ago, I don't want to go into any detail on the story now, but I received a call from a Leaf-Romani father, which basically changed our life and the direction of our company. So if anybody's interested, I'm happy to tell the story after. But right now, I'll try and tell you in the next 20 minutes a little bit about a clinical stage molecule that we've been developing. I'll start out with a discussion of the somatic mutations and end up with some very recent data that we have in Leaf-Romani mice, which is unpublished, will be published very shortly, but is really, I think, potentially transformational. And that'll be the last bit of hyperbole that you hear. The rest I'll try and stick to the data. So someone just recently asked me how we'd come so far in such a short period of time, literally 2.5 years or so, to get to where we are right now with a clinical stage molecule and the potential for making an impact in Leaf-Romani. And I was reminded immediately by of the old Greek mythology about Atlas holding up the world. And someone then pointed out in antiquity, well, what is Atlas standing on? And the answer came back, well, he's standing on a turtle. And that didn't satisfy the individual. So the question, well, what's the turtle standing on? And the answer was, it's nothing but turtles all the way down. So I feel much the same way about how we've come to where we are right now. So we perhaps see a little bit further because we're standing on the shoulders of giants, and it's nothing but giants all the way down. Some of them are actually here today. So I'll start out with my homage to some of the giants in this area. You probably know that 1979 was a very big year. P53 was discovered in a number of places in the world, in the UK with David Lane's group, at Princeton with Dr. Levine's group, and at Sloan Kettering with Dr. Old's group. And until the late 1980s, it was considered to be an oncogene, just like all of the other genes that had been discovered to that point. And it was Dr. Vogelstein that identified it was actually a tumor suppressor. And now we're at the point where we understand that P53 mutations account for the important mutation in more than 50% of human cancers, and even higher in the group of the Leaf-Romani germline cancers. I think the circle has come full circle because it's now appreciated that while P53 can be a tumor suppressor, it can also gain function and function very much like an oncogene. I've included at the bottom here the tried and true diagram that you've seen already, and I put that up there only for the purposes of showing you These hotspot mutations, which account for roughly 28 to 30% of all human cancers, are susceptible to COD2. So there's been a lot of work done on the extent of the allelic mutations that P53 that COD2 is active in. The one point I'll just make is, that we have looked at two mutations down here beyond amino acid 300, which, as you've heard, is in the tetramer region. And both of those were actually sensitive to COD2. And I think it's, as you'll see, largely because they have the arginine to histidine mutation. And one of the things that will come out of this is that that particular mutation of arginine to histidine seems to be something that COD2 really prefers. The molecule up there is, I put it up there for a number of reasons. It's a very simple molecule, small molecule, about 360 Daltons. And the core part of that molecule is a thiosemicarbazole. And this particular class of drugs came out of the Bayer company in Germany in 1947 and was used to treat tuberculosis in Europe and was brought to North America, where it wasn't any better than the treatments available in North America in the 1950s, so it largely fell into disrepute because there was no use for it. Well, the other reason that this molecule is very unique is that it was selected, it was made, optimized, and then chosen by a series of computer simulations. So our company is a computer simulations company, and we focused a lot of our efforts in drug discovery and drug development. And one of the first molecules that we came up with was this molecule, which is COD2. And I won't go into the chemistry, but for those of you who do have a chemistry background, you'll recognize immediately that this has the underlying structure of what's called a metal chelator. And it's actually part of a new class of drugs, and I'll talk about the other two members of this that I'm aware of, but this is a class of drugs that's now referred to as zinc metallochaperones. And this particular drug has a preference for zinc over iron, which gives it most of its biological activity. The drug itself has been used in many cancers. We've done over 20 human xenografts so far, and that includes xenografts that have been done at MD Anderson down in Houston. And I want to acknowledge and thank Dr. Gordon Mills from MD Anderson for doing much of the work that I'll talk about initially and helping us to understand the mechanism of action. The drug is currently in phase 1 at MD Anderson, so it's a clinical stage compound. 6 women are now receiving the drug, and it's being used for gynecological cancers. The reason for that is particularly ovarian cancer, but gynecological cancers in general have a very high prevalence of P53 mutations. These are, of course, somatic mutations. And so far, so good. We have also done some work that I'm going to show you in a moment in head and neck cancer, in which P53 mutations are also very common. And then I'm pleased to at least suggest to you that with the help of Dr. David Melkin at the Hospital for Sick Children in Toronto, we're now in the planning stages for a Leaf-Romani phase 1 clinical trial. And what we're going to do is to wait for establishing the phase 2 dose from the phase 1 study, and then with David's expert guidance, we'll be recruiting in a multi-centered way for folks with Leaf-Romani cancers. As you'll see, the drug works well by itself, but is particularly spectacular when it's combined with conventional chemotherapy and more recently with radiation. So this is some of the very first work that we did when we weren't sure exactly what we were looking at. The study that you'll see there is a comparison of 2 cell lines. In the top panel is TOV112D, which has a very specific mutation, the 175H mutation. And below that, you'll see a lung cancer cell line that has wild type P53. So this panel over here demonstrates differential staining for mutant p53, and this is without any CAUTI treatment. And what you can see here is there's predominantly mutated p53 in those particular cells. After a very small amount, 10 nanomoles of CAUTI2, you can see very significant change from mutant to wild type p53 configuration. So this was the first real evidence that we had that we're bringing about a conformational change in mutant p53 protein. And the other point I'll make here is you can see that there's no effect at all on the normal healthy cells that have the wild type p53. This is very important because it's consistent with everything we've seen in preclinical development and in the clinic. It seems to leave healthy cells alone and only attack those cells that has mutant p53 protein. This is the protein quantification studies that went along with the fluorescent antibodies, and we're now quantifying the protein in these cells, and you can see the same effect that you saw previously. You see a decrease in the mutant p53 with a substantial increase in wild-type p53 conformation in those cells, and once again the wild type is essentially unchanged. So this was very important evidence for us that we were likely dealing with a small molecule that brought about a conformational change in p53, with, importantly, reactivation of the function of p53. So thanks to a lot of the work done by Gordon, we were able to demonstrate very quickly that we induce p21, which is very important. We induce PERP and also induce PUMA. So all of the right targets were being activated by this drug as well. There is a whole ream of data with blots that I didn't include, but essentially shows exactly what I've said, that the drug activates p53 with resultant activation of specific downstream targets. We have similar results to those results that I just showed you in many other cell lines that we did, and cell lines that Gordon Mills has done at MD Anderson. I've included this little table up here for historical purposes, but this all started with an evaluation of what we thought were hotspot mutations and whether or not CAUTI2 was interacting with hotspot mutations. And this actually threw us a bit of a curve initially and resulted in a bit of a delay in terms of getting to the truth. So what you can see here is this is a 2x2 table, and we carried out something called a Fisher exact test, looking for differences between the treated cell lines in terms of whether or not they have a p53 mutation or not. And one of the things that showed up was we showed a number of cell lines that appeared to have wild type p53, and yet were still very responsive to CAUTI2. So of course the naysayers automatically said, well, you don't really understand how it's working, it's not p53. Well, subsequent work really showed that there was an explanation for that, which is proven out over time now. The cell lines, these 5 cell lines, either had p53 family mutations, so there's p63 and p73, which are very close family members. The other thing is that the molecule modulates the AKT pathway as well. So if there is a mutation in PI3K, AKT, or mTOR, we also see a very beneficial effect from this molecule. The work at the bottom is Dr. Mills' work, which I wanted to show you, and this was some of the early work that he did. All of the numbers, or the letters in red, are letters that he determined to be specific allelic mutations that were responsive at sub-micromole, nanomolar levels to CAUTI2. So a very wide range of allelic mutations of p53. I'll talk about this one in a minute, the R248Q, because I've got a xenograft, of course, to show you why that's important. This is the xenograph that got the folks at MD Anderson very excited about doing the phase 1 study. What you're looking at here is a xenograph, so a mouse model growing a human tumor, and this human tumor is particularly tough. It's a cell line called OVCAR3, and it has a R248Q mutation, one of the ones that's sensitive to CAUTI2, and it also is resistant to traditional chemotherapy. So we used it as a very high bar to see whether or not we actually had anything. And this particular cell line is resistant to adriamycin, cyclophosphamide, and platin. So all of the traditional drugs used to treat ovarian cancer, this particular cell line is resistant to. And what you can see here is at a very reasonable dose. This is 40 milligrams given to the mice 3 times per week. And you can see here that at that dose, the tumor literally melts away. In fact, I got a call from Dr. Perpatnik's lab saying we need to stop this. The tumors are disappearing so quickly in the treatment arm that we're not going to have any tissue left to analyze. So we did stop that arm, and that's why there's an abrupt cutoff there. The animals did very well. We just had to stop the trial in order to get any tissue at all to analyze. The brownie orange line is 20 milligrams per kilogram, which is a dose that the animals really don't even know that they're taking. And you can see they're typical of a tumor suppressing agent. There's flat line. The tumor just basically stops growing. And we've seen this over and over again in all of the xenografts that we've done so far. This is more recent data. This is unpublished. What I've shown you up to now can be found in a journal article just published this week in Oncotarget, Volume 7. And from now on, this is all new, unpublished data which is being shared with you for the very first time. So this information comes from Jeff Myers' lab at MD Anderson. Jeff Myers is a head and neck surgeon and internationally known cancer researcher. And this is the data that we've generated that is the basis for the clinical trial that will be starting shortly in recurring head and neck squamous cell cancer. The reason for that is in the HPV negative recurrent head and neck cancer, the p53 mutation rate's about 70%. So I'm going to move along quickly. I'm running out of time. But as you can see, basically the tumor once again stops growing, and this is a very, very difficult to treat head and neck squamous cell cancer growing in a mouse model. The good news continues. We've also done some work recently looking at synergism, and we've chosen to look at cisplatin. We have some in vitro evidence that CAUTI2 is very effective with virtually everything we've put it with, and what you're looking at here is simply the survival or other way around, death of cells that are exposed to the drug, cisplatin, or the combination. And you can see at the top line, the combination is very much greater than any of the, than either of the two drugs alone. Similarly, what we've done here is to generate the index. This is an index that's generated from comparing the individual IC50 curves with the combination curve. And what you want to see is that this value is less than 1. And you can see here that actually as doses increase, the synergistic effect with cisplatin is even higher. Right here, this is a xenograft to confirm this. So once again, we're looking at a very difficult to treat head and neck cancer with cisplatin up here, no effect. CAUTI2, a little bit of an effect on its own, but certainly the combination is a very dramatic effect, and this is why we're going to do the phase 1 study as well. I'm about 2 slides away, so I hope I can I have 1 minute? Okay. So we also recently looked at using CAUTI2 in combination with radiotherapy. There was reason to believe, based on in vitro work that we'd done, that the drug also sensitized cancers to become susceptible to radiotherapy, even when they'd been previously resistant to radiotherapy. And that's what this is showing. Essentially, as you increase the dose of radiotherapy and increase the dose of CAUTI2, you see remarkable effects on tumor killing with the combination of the two. This is the next to last slide, and this is the really exciting stuff. I hope I can have time to go through this. I'll just take a minute to tell you that this is specific to Leishmania. So about a year ago, we obtained frozen embryos from National Cancer Institute and grew those up, and we now have a population of about 60 Leishmania mice that bear the mouse equivalent of the most common mutation in human Leishmania. And what you can notice here, these are once again differential antibodies looking at the presence of mutant or P50 or wild type P53. So what you can see here once again in these animals, this is the first time to my knowledge that this has ever been done successfully, but what we've done is to treat these animals for a variable period of time, and these animals that I'm showing you now were treated for 1 week. 3 doses of COD2. The animals were then sacrificed and organs obtained and assayed for wild type or mutant P53. And what we're showing here is with low dose of COD2 for 3 days, a significant drop in the mutant form of P53, and similarly an increase in the wild type form of P53. So this is in Leishmania mice who are carrying the same mutation that is very common in the human condition. Over here, this is just simply to show you that there's no change in the total P53, so what's going on is nothing to do with protein synthesis or gene induction, but really a true conversion from the mutant to wild type P53. I should also tell you that the animals tolerated this very well. There were no animal deaths and no signs of the animals being ill during the study. So that's also very encouraging. And this is the last slide. I think I've run over my time, so I'll stop there. Thank you.